Good afternoon. We'll go ahead and get started. Happy New Year. Welcome back. You've made it through the midway point of our Dementia and Antipsychotics in the Long-Term Care Setting Quality Improvement Initiative. Again, this is a partnership between Vanderbilt University Medical Center, Vanderbilt Center for Quality Aging, and Q-Source, the Quality Improvement Agency here in Tennessee. This is session number 4, Principles of Non-Pharmacological Management and the Formulation of Behavioral Care Plans. If you missed any one session 1 through 3, or you have other staff you'd like to see the presentations, those are available on our website. And here's a look at the upcoming presentations. You should be seeing our project website pop up in the chat pane, which, depending on how your screen is set up, will either be on the right-hand side or at the top of your screen. We will have all the phone lines muted during the presentation. It just provides a better listening environment. If you have questions or comments for our presenters, please use the chat feature to connect with us, and Britt will be monitoring that today. So to test out, make sure you know how to use the chat pane. Go ahead and type in your facility name and how many people at your facility are currently viewing the webinar. As you type that in, another note, Britt will be feeding you some helpful information and links during the presentation. Also, we have, again, a few more polling questions, so pay attention to those to pop up on your screen as well. We'll get right into today's presentation. It has a lot of examples and lots of good in-depth information. And we have back with us today Dr. Jim Powers, who is he's a lot of things, but he is, most of all, most importantly, is a geriatrician here at Vanderbilt University Medical Center and oversees the residents on their geriatric rotation, and he's just a fabulous physician, and we're lucky to have him with us today.
Thank you, Emily, and I'd like to also introduce our colleague, Harry Plummer, who helped to produce this session, is not able to be with us today, but one of our colleagues, Anna Cook, who is a psychiatric nurse practitioner, will be commenting on some of the slides. This is the 4th presentation now, Principles of Non-Pharmacologic Management of Behavioral Disturbance in Dementia and the Formulation of Behavioral Care Plans. I hope that as we present that you will think of patients, residents that you care for, that have had behavioral problems, and not only the difficult patients, but also your success stories, because we would like to hear from you in future presentations to discuss some of these cases. We think that having experiences that are authentic and live from the field will be very helpful for our colleagues. And these will be de-identified, of course, but we have a team of experts that will be reviewing the submissions. We have 4 physicians, 2 of them are geriatric psychiatrists, and we have 3 nurse practitioners, psychiatric nurse practitioners, who will be reviewing these cases. I'll come back to that. The objectives of this session are to review the contexts, causes, and consequences of behavioral disturbances in dementia. Yes, we're going to go into depth looking at these behaviors, both the antecedent factors and the consequences of the behaviors, as well as the approaches to these behaviors. Number 2, we're going to discuss the basic principles of non-pharmacologic interventions. There are many of them, and we're going to refer you to some good resources that will be posted on our website for you to think about in individualizing, making patient-centric care plans. And also, number 3, how to create a behavioral care plan. We know that the surveyors are going to be looking for evidence of expertise as well as competency in using behavioral care plans and modifying them, and we'll discuss that in the cases that we present. This is a very rich slide here talking about the context, causes, and consequences of behavior. Think about the context. Most people with dementia will suffer from some form of behavioral disturbances. This probably increases as the resident progresses from mild to severe Alzheimer's disease. It may be self-limited, but the duration and the intensity will be very individual. There are going to be personal and environmental, chronologic, maybe even psychological components to the context, and we'll give examples in all of these categories because I know that you are experiencing them in the field. The consequences of the behavior is also very complex. There's a lot of distress, not only for the care provider, but yes, for the residents as well. They are distressed, and the behavior is a manifestation of that distress. We know that the difficult behaviors create an added burden for caregivers, and liabilities. We are very much aware of that. And the fact that there are so many patients who are prescribed antipsychotics means that these are very difficult behaviors sometimes to control. We also know from the previous presentations that antipsychotics can have many negative side effects, and that we, as a country, prescribe them too frequently for our dementia patients in long-term care. The causes of the behavior take a lot of understanding on the part of all of us as providers. When we know our patients well, when we are patient-centered, we try to find specific reasons for behaviors. And it can take a lot of creativity, sometimes a lot of teamwork and information from family to really understand the behavior. Pain is a very common cause if we start with the physical causes. And the patient may not be able to express the pain verbally. There may be nonverbal cues, in fact, behavior cues that pain is ongoing, and you have to suspect that something might be a problem. This can be a problem related to an infection, perhaps constipation, perhaps due to medication, perhaps due to a fall that was unwitnessed. You can see that you have to be very creative, a very good diagnostician to try to come up with an answer. Think also in terms of psychological causes. Loneliness and boredom are easy to understand, but how about the loss of intimacy? How about the patient who doesn't remember that they're a widow? Or perhaps they haven't seen their family for a while, or maybe it's a new admission to the facility, and they're adjusting to that. This can take many weeks and months, as all of you know. Think also about environmental causes, overstimulation, or perhaps lack of a new environment, being indoors, not having a real awareness of the passage of the day, of the seasons, can be very difficult for patients. Overstimulation as well, being in a room with other individuals who have their own needs, or perhaps too much noise. These are all things that can be detrimental to a patient with dementia. Disorientation is also very common, particularly with new locations, new room changes, new roommates, new personnel. And then perhaps institutional routines can conflict with time-valued routines of care that the individual may have had, or self-care, and sticking to a time clock sometimes does not always jive for a dementia patient. And there can be emotional, psychiatric concerns. On top of a dementia, you can also have depression and anxiety, and with a new medical problem or pain, delirium can also be a component. So approaching the patient or the resident with a behavioral disturbance really takes a well-rounded approach and can include some or all of the issues or the causes that we have discussed. The principles of non-pharmacologic management are inherently person-centered. They should be tailored to the individual's specific behaviors and needs, including the causes and the situations involved. It often involves a team approach to understand the behavior itself and to come up with creative solutions. This includes the resident to the extent that they can participate in expressing their needs and desires and preferences, as well as the family. And the staff as well. This includes direct care staff, of course. They're very important. They're right at the bedside, but also social services, activities director, RNs, even nursing directors, to really come up with an approach that is going to work for that individual. And this person-centered approach should be attempted before using medication. And it is obviously something that requires reassessment. So we recommend strongly the ACT, Plan, Do, and Study cycle, continuous process of quality improvement. Did it work? So we have new information that makes the plan different now. Can we reinstitute that? Can we update our care plans? These are all very critical factors in involving a person-centered approach to behavioral problems. We would recommend using a stepwise approach to developing the non-pharmacologic management strategy for the individual behavior that's expressed. First of all, ask the right question. Pick out the behavior that is of concern and define that problem behavior. This might be a frequency, it might be the time of behavior, it might be intensity. Very important to describe the behavior accurately. To answer that question, what is the specific problem going on with that individual? Assess the behavior. Look and see if it has been expressed before. Perhaps it is a new behavior in response to new environmental challenges. Institute an environmental modification, if at all possible. Think of that. It might be that a room change is necessary, a roommate change is necessary, a routine change is necessary. We'll have some examples as we go through the slides. And implement your treatment strategy. Decide on what might be the best person-centered approach for this behavior, for this individual. Implement it, study the responses, and then make adjustments as needed. This stepwise plan actually comes from the University of Iowa ADAPT program, and we'll be talking about some other tools that they have developed, and these will be appended to our website for all to access even after this presentation. The University of Iowa ADAPT program is a non-drug management pocket guide that stands for Improving Antipsychotic Appropriateness in Dementia Patients. This also is a complicated slide. However, it does, in a very thumbnail sketch fashion, show you a lot of different strategies to evaluate, to treat, and to monitor patient behaviors. And this, again, will be on the website, and we're going to go into detail in certain parts of it. But I thought that you would like to see this, even though it's on a small slide. Thank you. Okay. Basically, it has 3 steps. Step 1, identify, assess, treat the contributing factors to the behavior. Step 2, select and apply non-pharmacologic interventions. And step 3, monitor outcomes and adjust the course as needed. And yes, we're going to give some examples of these. But that is the basic strategy. So how do we identify, assess, and treat the behavior? Step 1. First of all, focus on one behavior at a time. Determine the behavior that needs to be assessed. What does it look like? provide details so that others would be able to recognize the behavior. How long does it happen? What's the duration? How often? What is the frequency? And how severe is this behavior? The intensity of the behavior. Very important to really describe the behavior that is of concern. The next step is to identify what triggers the problems. Others have called this the antecedents to the behavior. Antecedents can be viewed as predictors of the behavior. If we know when the behavior will occur, then we can prevent it from happening, hopefully. What preceded the behavior? What precipitated it? Was it an individual? Were they different people? Who? Where? Was it a certain place, environment? Maybe the dining room, the time of day, when, and activities that might be taking place at the same time. And the next step is to reduce and eliminate those triggers, if you will. Look at the consequences of the behaviors. Consequences are not always negative, but they are what lead to learning and maintaining the problem behavior. Is there any reinforcement that's occurring? Anything given or taken away that increases the behavior? And be person-specific in terms of looking for this reinforcement. Are there any punishers? Anything that's given or taken away that decreases the behavior? And this can also be very, very person-centric. Also look at any consequences that start a behavior that may not be the consequence that maintains it, such as situation specifics. These are all very important strategies to really hone down on that problem. And of course, document outcomes and make changes as necessary. Okay, so we focus on one behavior at a time, such as frequency. Is it once a day or many times a day? The duration, is it a few minutes? Or is it throughout the entire process, say, taking a bath or getting dressed? And the intensity. Is it very mild or is it really bad today? And describe the specific details and characteristics of the behavior in your charting as well as your care plan. To identify, assess, and treat, ask the team, what is causing the problem behavior? Does anybody know what is making it worse? It might be the nurse's aide who really has the key information. Is it time of day? Perhaps the type of care that's being provided. Are some staff better able to resolve the issue and calm the resident? If so, what do they know? What strategies are they using? All very important to share with your colleagues in the better care of the patient. So yes, we have an example. We have a table that can be used, and we're going to take a generic Mrs. Smith, and her targeted behavior is screaming. And we'll look at the duration of the behavior. Thankfully, just a brief episode here, but very, very disturbing to all, including Mrs. Smith, when it does happen. Well, let's look at the frequency. Oh, my word. It's happening many times a day, and there doesn't seem to be a real predominance, does it? It seems to be all of the time, and the intensity is all over the map. Well, this is helpful. Perhaps in terms of describing it might not be as helpful in terms of addressing it. I think it's going to take some creative strategies from all the staff, thinking about what's going on in the day shift, what's going on in the evening shift, to try to resolve this. Such a constancy might suggest that there's a continuous disturbance going on, even though the screaming comes out periodically through the day. Okay. So identify what leads to these trigger problems. There's some interventions that I'm sorry, change my script here. And assess the tools here to use. back to what we talked about before, physical. Could it be pain? Could it be a new infection or illness? Could it be medication side effects or sensory deficits that is triggering this discomfort? Incontinence certainly can do this throughout the day, as we saw in Mrs. Smith's form. This can occur many times at any time during the day, and could be one trigger if appropriate. Certainly the solution is more straightforward. The environment, could it be the type of stimulation such as noise or lighting or perhaps lack of lighting that is causing this? Maybe it's the approach that certain staff have towards this individual. Some seem to be able to approach the patient in a caring way that does not stimulate resistance, and others, well-meaning, might just have a different approach that is not acceptable to this individual. Could it be routines and expectations of the institution? It's time to get dressed. It's time to have breakfast. It's time to take a bath. And maybe lack of cues or prompts to help warn the patient that it's time to go to lunch. It's time to go to bed. Also, look at the triggers to these problems in terms of psychological or psychiatric components. Could it be loneliness? Could this be a new admission? Could there be some fears or worries that maybe there would be no visits from a family member? And family, perhaps other staff through the day may get more information, and putting that information together in a team approach may come to some solutions, some reasonable explanations for the behavior. It could also be coexistent depression or anxiety or other mental illness superimposed on the dementia.
So to give you a little bit more background about Mrs. Smith, when the care partners or nurse aides were asked about her screaming, they mentioned that her family had brought in a new mirror to put over her dresser because they noticed she wasn't taking care of herself as well, that her appearance and her hygiene had gone down. And the staff, the direct care staff seemed to notice that mirror, the timing of that mirror being placed in the room coincided with the start of the screaming. So that was the start of assessing the screaming behavior.
Right, and this would have been an environmental change. And the resultant behavior was that of fear and confusion. Knowing this was critical in describing the next steps of the care plan about what to do about this mirror and behavior. And the mirror was removed. However, the treatment would be to remove or eliminate what leads or triggers the problem behavior. And it could be, if it's a physical problem, otherwise to address the pain issue, address the constipation. Environmental, as in this case, remove the object that was triggering the behavior. And it turned out that more history. This actually is an authentic case. Mrs. Smith was always very concerned about her appearance. She was actually a very, very beautiful woman who made sure that she was always well-dressed, well-groomed, and she just could not believe who she was seeing in the mirror, and this frightened her, particularly if others might tell her that this is actually her that she was seeing. That was just not acceptable. And so this frightening older woman in the mirror was disturbing her. If it's a psychological issue, reassuring, engaging the family or others, friends, other associates might offer some relief, and social activities can also take the strain off a psychological concerns. Reminiscence therapy, for instance, has been very, very effective in redirecting individuals and calming them. And psychiatric disturbances can be treated with the same support measures. Perhaps medications are useful there, not antipsychotic medicines, but other medications. So once we looked at Mrs. Smith, did the frequency, duration, or intensity improve by treating the contributing factors? And we will tell you yes, when we removed the mirror, she did improve. And we also reoriented her and redirected her and engaged her in more meaningful activities. And what you can see here is a follow-up over different days of the behavior and seeing it, in this case, be extinguished. Okay. So this is one example of use of a charting tool to look at the frequency intensity of a target behavior and tie it to the intervention, which is described below. We'll give another example of a physical phenomenon, and this is bath time. Bath time for dementia patients can be very disturbing, particularly if it's done at a time when the individual is not interested in having a bath. Think of it, you take your clothes off, there's a stranger who's with you, it may be cold, certainly cold after the bath, and you may be brought to another area of the facility. It can be very frightening. And it's important to understand this from the standpoint of the individual. There are other ways to help demented individuals who are resistant to bathing. One technique that we have used is to actually use bedside sponge baths. Think of the difference dragging a person down the hall, kicking and screaming to a bathing area versus having a gentle approach in the bed. In our case, we actually had a nurse who would sing to this patient, calm them down, and just expose an arm, just expose a leg, do a gentle sponge bath with a barrier underneath the limb, and then gradually move to more critical areas like the face, like the abdomen, like the chest, and the perineal area. Just expose one area at a time, using, again, soothing techniques, warm water, and drying, and clothing the person after exposing that area. Much more satisfactory for all involved. Documenting your outcomes is also important. Step one, we talked about identifying and treating the contributing factors, and then applying them, and seeing what happens. If the behavior is manageable, we monitor the outcomes and adjust the course as needed. If the behavior persists, you've got to rethink. Go remember the plan, do, study, act cycle. Go back and see, are there other antecedents to the behavior? Are there other contributing causes that we may not have thought about? Was a minor contributor now a major contributor? Is there more information from talking with the family or the staff? And document your outcomes and adjust your care plans accordingly. In 2014, 5 states piloted a surveyor tool looking at dementia care. These were California, Illinois, Louisiana, Minnesota, and New York. CMS is sharing these revised materials, and we are going to post them as well on the website. The facilities can use these tools to assess their own practices, but also be aware of the yardsticks by which we're all being evaluated. Is there training for staff in dementia care, in behavioral approaches to dementia disturbances? Is the care person-centric? Is the dignity of the individual preserved? Are the facilities using nationally recognized tools, toolkits, and recommendations, such as the Iowa ADAPT program? Does the care plan include monitoring the effectiveness of the interventions and revisions? All very important, and things that we know that CMS will be looking at. We don't know when and in what form individual state surveyors will be using them, but they have all been briefed on the outcomes of this pilot information. This also will be in the website, or on the website for you, and is a summary of the kind of practices that will be assessed. For instance, has the resident indicated distress or engaged in behaviors that appear to be distress while in the facility? And if so, what is the frequency, the duration, the intensity? Did the staff describe the specific experiences of the individual and underlying causes? Does staff describe related factors with enough detail to permit the underlying cause to be identified? What are those triggers that we've talked about? If this is a sudden change for the resident, did staff contact the interdisciplinary team, including the family, to discuss the problems and perhaps to get more information on how to intervene? And if the medical causes are ruled out, does the staff attempt to determine the underlying cause of the distress using individualized knowledge, person-centric knowledge, and communicate it with the direct care staff? Did the staff evaluate the cognitive patterns also present, and did they monitor the outcomes? All of the things that we've discussed here in a summary sheet.
So we've come to our first polling question. Staff should assess one behavioral disturbance at a time for an individual resident, assessing a possible cause and what worsens the behavior. There we go. So select your answer, true or false, and make sure you hit the submit button. And we'll have our 30 seconds of awkward silence until the answers come up. Oh, excellent. Not all 9 responders selected true, which is the correct answer. So it seems like everybody's paying attention. And we have one more polling question before we move on to the next section, and that is, a resident with a behavioral disturbance requires a team approach to fit the intervention to the person, true or false? Again, make sure you hit submit after you select your answer. All right. Again, everybody answered correctly. The correct answer being true. It definitely requires an interdisciplinary and group approach. So now that you have all done stellar on part 1, Dr. Powers is going to tell us what to do if identifying and assessing those and treating those antecedent causes doesn't work.
All right. Select and apply non-pharmacologic interventions based on the abilities, preferences, and resources of the individual. This involves, again, a knowledge of the patient, and probably using another example may be helpful here. I'll give the example of a couple that was placed in a long-term care facility. Both husband and wife had dementia, and they were placed in the same room, well-meaning. They had been married for many years, and it was a very reasonable first approach. Unfortunately, they did not get along. If you think about it, they were not able to see each other as they had remembered each other when they were younger. Their roles were different, their reactions to each other were different, and they really had difficulty as roommates. So we had to adjust the caregiver approach. Rather than treat them as a couple, we had to adapt, change the environment. In this case, thinking with the family's involvement, what about trying the gentleman with another gentleman as a roommate and the woman with another woman as a roommate? How would that work out? And again, this is an authentic example, and it's only one, but that actually worked out very well. Both husband and wife had very advanced dementia, and while they remained able to see each other at any time, they were often put together during meals and during leisure activities. They remained good friends, but not having to be roommates. And that was, I think, a very person-centered approach done very tastefully and thoughtfully with family input for, I think, the benefit of both individuals. So in this case, the environment was changed, and the best evidence that we have is that they were treated humanely and very respectfully, but that we did not insist on identifying them as a married couple, at least as far as the room assignments were concerned. And staff were then trained to understand what went on. Perhaps you will also have examples like this. Again, success stories or maybe cases where things just aren't working. We do want to hear those stories and hope that you will feel free to send us that information. And Emily will tell you about how to do that later in the program. In the example that I just used, the patient's retained abilities were very limited, both husband and wife. And while their preferences, the family's preference would have been originally to have both as roommates, it turns out that was counterproductive. And the facility did have the resources and the ability to change the rooms. And we paid particular attention to the cognitive level of both parties concerned. Their functional level was actually not an issue. They preferred routine and daily schedules and tried to adhere to them as much as possible. So developing a person-centered plan involves adjusting the care provider approaches to what is best for the person. Adapting and changing the environment is often a very appropriate first approach and often works, as it did in this case. And selecting and using the best evidence-based interventions is appropriate. And in the tools that you will have uploaded to the site, you'll see many dozens of suggestions about different behavioral techniques, different solutions to common problems that you can use for applying to specific patient care needs. A personal approach might involve cueing the individual, prompting them, reminding them, redirecting them, focusing on their concerns, reassuring them, very gentle touches as indicated, remembering that touch can also be seen as a violation of personal space, so it has to be appropriate. You have to work with the individuals and if they're expecting to be touched in an appropriate way. Reasoning and teaching new routines, unfortunately, does not work with dementia patients. Simplifying the tasks, offering limited choices, but some choices is appropriate. We had another example of a woman who would change her clothes many times during the day. She also was very concerned about her appearance when she was younger and did dress very well. But the staff would talk with her in the evening and have her select her wardrobe the evening before, and that was hung outside the then locked cabinet door, and that was what she was going to wear the next day. But it offered her some choices, and they would remind her that that was what she selected, and that they would go ahead and help her get dressed. And also remember that long-standing patterns are hard to break in patients, in residents, and adjusting to their needs and desires as much as possible in daily routines is appropriate. Communication style is also important. Simple words that are easily understood, phrases that the residents will understand. Wait for them to respond. Do make eye contact and treat them with respect. The awareness of body language as well. Many dementia patients will not be verbal, at least not in every interaction, and so looking at body language will tell you a lot about their response. Confrontation is not recommended, nor challenging the individual's beliefs, but accept the belief as real, at least to the individual at the time, and reassure and comfort, distract, redirect as appropriate, is always helpful. In terms of amazing dementia care plan, specific strategies that might be involved could be timing. Perhaps a sponge bath may not be appropriate all the time for every patient. Perhaps you could negotiate the timing of the bath, maybe after breakfast, or maybe we could do it in the afternoon today. These are important. Perhaps the individual also wants to have their hairstyle as well after the bath. That could be a way to condition them to accept the bathing because they know they're going to get their hair done afterwards. Or you could tie it to dressing routines. In terms of environmental challenges, many things in the environment will lead to confusion. And if you can anticipate that, avoiding confusion by eliminating the things that appear to distress the individual are very helpful. Noise, I think, is a very common ambient environmental stress for many facilities, and having quiet time, or remembering that certain times of the day are important to individuals, and maybe they would like to be by themselves. Taking a person-centered history with family involvement may help. Adjust the level of stimulation, and it might be that a lack of stimulation may be a problem. Getting the person outside during nice weather may be very appropriate. Positive stimulation for a number of individuals who can't do that on themselves. Assist, but don't take over their functional care. Trying to promote independence as much as is possible and assisting when necessary is a part of appropriate patient care. And involving the individual in meaningful activities. Are there activities that are helpful for this individual, perhaps related to prior occupations? We had occasion to have a gentleman who was a mail carrier, was in the facility, very demented, but we did let him pass out letters and cards as they came in to folks. Perhaps if there's a pet in the facility, having some pet care duties, or we've had others who would like to help make beds. We've helped them participate in making their own room, straightening up their own room, and changing the setting when appropriate. It may be that there are some timeout examples in the day room that would be appropriate. There are some facilities that have tried to make the environment a little more environmentally appropriate, more greenery, plants in the environment. Some will have distribution of medications in the hallway or in the common room as opposed to in the individual's room, more of a meal type setting. This can be very calming and very much more home-like for many individuals. Perhaps also decorating the dining room, having some cushions on the chairs where appropriate, and tablecloths to improve the setting. In terms of married roommates, I've given an example of one instance where we had to separate the individuals, but on the other hand, it may well be that for some individuals, having their spouse as a roommate is appropriate, and having some privacy as well is a strategy that may work for some families. Selecting and applying interventions should be evidence-based. For the agitated or irritable patient, this again comes from the toolkit that will be posted for you from the University of Iowa. Redirecting, distracting, and individualizing therapy is always appropriate and should be tried before medication. For the patient that wanders or is bored, again, engaging them, distracting, perhaps they need to be outside, perhaps they need to have some physical activity. If the individual is resistant to care, try changing the residence routine or try to assign different staff to their care. Okay, so we'll provide another example, I think, for an intervention. We had an individual who was very agitated and was recently admitted to the facility. He was a widower, and so there was no family, and the staff was quite distressed. At about dinner time every day, he would become quite difficult to deal with, and this went on for some time. He was at risk for restraint, at risk for antipsychotics, certainly, and it turned out that one day a friend was visiting, and the nurse that was on duty was very kind to this gentleman and said, please tell us more about him. Why is he agitated in the evening? And it turns out that the friend said that he had been a long-distance truck driver, and he had been used to calling his wife about 6 o'clock every evening when he couldn't be home. And he'd say, honey, I'm in Tulsa. I'll be home tomorrow. But he was missing his wife. Is why he got agitated. He didn't remember that she was no longer present, but he did remember that he missed her at about that time of day. And so the staff put together a book to help him reminisce, a scrapbook, and took that out in the afternoons so that he could reminisce and avoid being agitated. And he actually improved quite dramatically. That was a success story that our staff were very pleased to share with us, and perhaps you will have some others.
Okay, we've come to our last polling question of the session, so I won't ask too much more of you. but which should be the first step in intervening to reduce abnormal behavior in a patient with dementia? And you can see your choices there are institute environmental modifications, start a behavioral treatment plan, obtain laboratory tests, interview the family or care providers regarding the behavioral problems, or begin psychotropic medication. So what would be your first step? Is the question clear? Yeah. Okay. So once you select your answer, make sure you hit submit. Oh, everyone chose interview the family or care providers regarding the behavior or problem behavior.
I like that.
That was a little bit of a trick question from us because we, as a team, discussed that perhaps sometimes obtain laboratory tests could be your first, depending on what the behavior is and what the symptoms initially are. So.
I think it is important to get more information about the behavior from family, from the individual and other caregivers. Sometimes, despite that, having some laboratory tests finding a urine infection or something new is also helpful. So there actually are several correct answers here. That's the trick part of this question. But I agree with the responses that you've submitted.
So we ask just one homework assignment of you, and that is to choose one or two residents and create a behavioral care plan before session 5. So that should include monitoring the frequency, duration, and intensity of the behavior for at least 1 week. You're more than welcome to use the worksheet that Dr. Powers used with the first example. That is available on our website under the Session 4 tab. And I believe it was attached to your invitation to this webinar. So we ask that you give it a try, either use that format or something else that you have in your chart. And if you could share it with us, be identified, of course, you can email that to Britt or myself. And we'll also make sure that contact information is up on our website.
Right, we'd also encourage you to share your successes as well as your challenges. Brief clinical summary, because for sessions 5 and 6, we are going to use these. Again, we have a panel of experts that will give some recommendations, and we would like to interact with you with live cases, authentic cases from the field.
And this is just a review of the ILA ADAPT tool. The steps we walked through today, we will pick up more with step 3 during session 5. If you would like to see session 4 again, or you have other staff at your facility, especially direct care staff, since we've discussed how important they are in the care planning process, we'll be doing our morning presentation on January 28th. And if you're not going to attend that session, then we'll see you back here for session 5, which is the actual implementation of behavioral strategies, as well as managing pharmacological interventions. And you can see the dates and times there. Again, can you tell we want your cases? We're going to keep reminding you, whether through email or Facebook or our website. We really, especially during sessions 5 and 6, we want to tailor them to you and your needs. So this is your chance. A lot of expertise in the room, so we encourage you to share those. Does anybody have questions for Dr. Powers? You can share those through the chat pane. If we can get WebEx to go ahead and post the final evaluation question, that would be great. Make sure you answer that question and hit submit before you log off if you don't have any questions.
Non-drug management pocket guides are available once it's be able to provide to the staff.
Yes, the Iowa Pocket Guide will be under the Session 4 tab on our project website. It's a great little one-pager. Any other questions? Again, don't forget to complete the evaluation question. And here is our contact information, our Facebook page, our various websites, email addresses.